Good afternoon. My PhD topic can be summarized as advanced strategies in improving outcomes during mechanical ventilation. My name is Csenge Szigetváry, a PhD student from the Department of Anesthesiology and Intensive Therapy. With my team, we phrased our vision as implementing personalized strategies in intensive care medicine on a broad scale, hence providing more effective and safer interventions. In order to get there, I would like to help disseminating scientific-based medicine in anesthesiology and intensive care. These are the three projects that I've been working on in the previous months. The first project is effects of individualized versus conventional PEEP settings on perioperative outcomes in patients undergoing abdominal surgery. This is going to be a systematic review and meta-analysis. What is important in this topic is that even during an uneven full anesthesia, the lung regularly collapses. We use positive end-expiratory pressure to improve the oxygenation by keeping the alveoli open, but its high level of this pressure may also cause harm by overstretching the lung tissue. An individualized PEEP titration may reduce the incidence of postoperative pulmonary complications and can still be associated with better oxygenation. The aim of our study is to investigate the effects of personalized PEEP titration on perioperative outcomes as compared to the fixed PEEP methods. What is PEEP titration? It can be done by several equipments, for example, electrical impedance tomography, optimizing respiratory mechanics, or using an esophageal catheter to measure transpulmonary pressure. Our question is whether the personalized PEEP titration method results in better perioperative outcomes as compared to the conventional PEEP settings. We would like to investigate patients who undergo abdominal surgery, and we would like to compare those who received an individualized PEEP with those who received a fixed PEEP settings. We are mainly interested in the incidence of postoperative pulmonary complications, PPCs for short. The clinical implication of this study would be improving oxygenation and reducing postoperative complications by personalized PEEP settings. We hypothesized that the individualized method reduces the postoperative complications and results in better perioperative oxygenation compared to the conventional PEEP settings, which is the current method. We have conducted a systematic search in October, and we ended up having a pool a little over 1,000 articles. And with my co-investigator, we managed to have 17 eligible articles ready for full text and data extraction. I would like to proceed to our next project, acute hypoxemic respiratory failure. This is going to be a new registry. I would like to highlight two important things here. One is that acute hypoxemic respiratory failure is the leading cause of need of admission and mechanical ventilation in the ICUs, and it is associated with a high rate of mortality. The second thing is currently there are neither registries in critical care in general, nor in acute hypoxemic respiratory failure in Eastern Europe. So our aim would be to prospectively collect high-quality data on standards of care, on procedures and on outcomes regarding the treatment of patients in Hungarian and international ICUs. Here you can see our current human resources, our team, and our planned funding, which is approaching external sponsors and also work in a collaboration with the Hungarian Society of Anesthesiology and Intensive Therapy. Data collection would be done by either CRAs or PhD students. It depends on the given center. Data will be collected with ECRF forms that will be edited by us, and it will go under a multiple step of validation process. We have defined so far these eligibility criteria. The inclusion criteria for our registry would be adult patients treated in the ICU for at least 6 hours since admission, and they should be ventilated invasively, and they should fulfill the criteria of either moderate or severe oxygenation problems regarding the Berlin definition of ARDS. Currently, we are working on the protocol drafting and preparing the ethical approval requests. Now I would like to continue with the third project, Hemoadsorption as adjuvant therapy in acute respiratory distress syndrome, ARDS. This is going to be a systematic review. ARDS is usually a secondary result of a dysregulated inflammatory host response. Since it's a hyperinflammatory condition, immunomodulation by extracorporeal cytokine removal could enhance lung recovery during the early course of the disease. Our aim is to summarize our knowledge on the role of hemoabsorption and investigate the effects of this adjuvant therapy on clinical outcomes in patients with ARDS. We phrased our question whether the adjuvant hemoadsorption therapy in refractory hypoxemic respiratory failure can hasten improvement lung recovery. ARDS patients would be compared depending on if they received hemoadsorption therapy or they only received the standard medical treatment. We are interested in the oxygenation improvement between and after the procedure and the ventilator-free days on the first 28 days. The research implication of this systematic review is to summarize current data on hemoadsorption therapy in ARDS for clinicians in order to help them in decision-making and designing further research. We hypothesize that this adjuvant therapy is effective in reducing the circulating cytokines, diminishing the pulmonary edema, and hence improving the clinical outcomes. We are currently in the preliminary search phase, and we are just before starting the PROSPERO registration. So these were the three topics that I've been working on, and you can see the planned submission dates. Before heading to the question, I would like to thank your attention and say goodbye with this quote from Konstantinos Kavafis' poem, "Keep Ithaca always in your mind. Arriving there is what you're destined for. Don't hurry the journey at all. Be better if it lasts for years, so you're all by the time you reach the island, wealthy with all you've gained on the way." Thank you.
I want to ask the question regarding the first project. So, what is exactly the personalized and the conventional PEEP? And so, if we are using this personalized PEEP, and what is the extra effort from clinicians and the people who are doing this procedure?
Currently, the view is that during anesthesia, it's better to use a lower tidal volume and also use PEEP, so an end-expiratory pressure. But usually, the standard and fixed PEEP is usually between 4 or 6 H2O centimeters. And via this equipment, we can measure that what is that rate when the PEEP can be still high, but most probably won't cause harm to the lung. And it depends on the technique. For example, as I mentioned, so fitting it to the respiratory mechanics, how we can reach, for example, the best compliance that can be measured by the ventilator and still reach a quite high PEEP. Or another equipment that can measure when is the pressure when the lung collapse more